Picture this, you're in the worst pain of your life. You go to the emergency room and you're treated like a criminal. The nurse rolls her eyes at hearing chronic pain. The doctor accuses you of drug seeking. Security gets called because you ask for help. Unfortunately, this is the ER experience for many chronic pain patients, and it's not rare, it's becoming routine. So today we're exposing the ER nightmare, the discrimination, the bias, the medical gaslighting, and why chronic pain patients would rather suffer at home than face this abuse. Welcome back to Painfully Real. Today's episode might be the most triggering yet because almost every chronic pain patient has an ER horror story, and most of us are too traumatized to ever go back. When chronic pain patients come to the ER, we're assumed to be drug seeking until proven otherwise. The moment you say chronic pain or mention pain medication, everything changes. The nurse's demeanor shifts. The doctor questions become accusatory. You're no longer a patient, you're a suspect. I experienced this when my CRPS spread to my left arm and face. Most staff didn't even know what CRPS was. They manipulated my affective limbs, causing extreme pain, and then refused pain relief and put me on a stroke hold. The doctor said, "You seem to have a high pain tolerance. Are you sure you need medication?" It's like, well, I have chronic pain. I have CRPS. I live at an 8 or 9 daily. This is a 12. Yes, I need help. It's like, well, let's try IV fluids and Tylenol first. For me, that translates into, I don't trust you. Prove you deserve actual pain medication. My CRPS had literally spread to new areas, and I still had to prove I deserved relief. Now, if you've ever been to the ER multiple times, you get labeled a frequent flyer. This is the ER's code for drug seeking. Never mind that you have a documented chronic condition. Never mind that you only come when things are genuinely emergent. That label sticks, and it poisons every interaction. Hospital systems now flag patients with multiple ER visits. Some have care management plans that are essentially blacklists, predetermined limits on pain management, regardless of your condition. And the cruel irony, the sicker you are, the more you're punished for needing care. When you tell ER staff your pain is at a 9 or a 10, they don't believe you. You don't look like you're in that much pain. If it was really a 10, you'd be screaming right now. And your vitals, well, they don't show severe pain. But this is medical gaslighting. And chronic pain patients have learned to function through high pain levels. We've developed coping mechanisms over years of suffering. Pain science clearly shows that chronic pain changes how the nervous system processes pain. People with persistent pain develop different baseline nervous system activity. It's called pain adaptation. Yet ER providers use acute pain standards to judge us, then dismiss us when we don't perform pain correctly. I've had nurses literally laugh when I said my pain was a 9, as if my suffering was a joke. And this is where things get truly horrifying. Chronic pain patients are threatened with security for advocating for themselves. If you push back when dismissed, if you explain your pain as unbearable, if you get emotional because you're suffering and being ignored, security gets called. You're labeled disruptive or aggressive, and you're escorted out, sometimes even banned from the ER entirely. The threshold for disruptive is dramatically lower for chronic pain patients. Behaviors that would be normal advocacy get reframed as aggression. Women with endometriosis removed for crying. Veterans escorted out by armed guards for asking about their prescribed medications. Elderly patients banned for saying, "Please, I need help," more than once. And this isn't healthcare. This is punishment for being sick. The red flag trap ER staff look for, red flags for drug seeking, asking for medications by name, reporting pain scores, appearing anxious or emotional, a history of chronic pain or previous ER visits mentioning certain medications don't work, arriving outside regular hours. But these red flags also perfectly describe legitimate chronic pain patients in crisis. Of course, we ask for medication by name. We know what's worked before. Of course, we report high pain. That's why we're here. Of course, we're anxious, we're suffering and terrified based on past experiences. But the red flags are weaponized to deny us care. I'm going to talk about the 7 critical failures. Failure 1 is not distinguishing baseline from crisis. Every chronic pain patient has a baseline. Mine's usually 5 or 6, but when I go to the ER, I'm in crisis at a 9 or 10. Something has gone catastrophically wrong. But ER staff see chronic pain patient and assume this is just my normal. They don't distinguish between daily pain and acute crisis requiring emergency intervention. Second failure is refusing to treat pain while investigating. The ERs often refuse pain management until they know what's wrong. We need to know what's wrong before we can treat your pain. But this makes no sense. If someone comes in with a broken leg, you don't withhold pain relief while doing x-rays. You give pain relief while investigating. But with chronic pain patients, ERs withhold pain management as a reward you only get if you prove something is really wrong. Failure number 3 is offering inadequate alternatives. Have you tried Tylenol? Let me give you IV Toradol. Have you considered meditation? To chronic pain patients who've managed their condition for years, these suggestions are insulting. Of course, I've tried Tylenol. That's why I'm at the ER, because those things don't work for severe pain. By the time we come to the ER, we've exhausted every option. Offering Tylenol to a chronic pain patient in crisis is like offering a Band-Aid for a compound fracture. Your 4th failure is not coordinating with regular providers. Most chronic pain patients have established specialists who know their conditions intimately, but ERs almost never call them. They don't check your normal treatment plan. They don't ask what usually works. They make decisions in a vacuum that often contradict your established care. Why? Because calling your specialist might result in them saying, yes, this patient legitimately needs pain management, and that would obligate the ER to provide it. Failure 5 is punishing patients for provider failures. When your doctor abandons you, when you can't get appointments, when you're stuck in the system and you use the ER as backup, you get punished for it. You're using the ER like a clinic, but what if you can't see your regular doctor? What if they dropped you? What if you're waiting months for a specialist? And the healthcare system created this problem by abandoning chronic pain patients. Then it punishes us for having nowhere else to go. Your 6th failure is the notes that follow you forever. See, every interaction gets documented. And once a biased note gets in your chart, it follows you everywhere. Patient appears drug seeking. Patient was demanding and aggressive. Suspects malingering. These subjective assessments become permanent. They poison every future medical interaction. They're shared across hospital systems, and you have no recourse. You can't challenge them. You can't add your side. You can't get them removed, even if they're completely false. And the last failure is using vitals to disprove pain. Your blood pressure is normal. Your heart rate isn't elevated. You don't look like you're in distress, but chronic pain patients often have normal vitals even during severe pain. Why? Because we've been in pain so long, our bodies have adapted, and using vitals to disprove chronic pain is medically ignorant, but it happens constantly. After multiple traumatic ER experiences, chronic pain patients develop medical PTSD. The symptoms mirror classic PTSD, intense anxiety about going to the ER, flashbacks to previous humiliating experiences. avoidance of medical settings even during emergencies, panic attacks in hospitals. This is documented, diagnosable trauma. And unlike other PTSD where you can avoid triggers, chronic pain patients can't avoid needing medical care. We're forced to repeatedly return to the environment that traumatized us. When the place you're supposed to go for emergency help becomes a place of trauma, where do you go? When chronic pain patients stop trusting the medical system entirely, we stop going to the ER even during true emergencies. We delay care. We try to manage everything at home, no matter how dangerous. And sometimes that kills us. Heart attacks where patients delayed care for hours because they feared ER mistreatment. Appendicitis leading to rupture because patients tried to manage it. Strokes where treatment windows were missed. Healthcare trauma has literally made the ER more dangerous than staying home for many chronic pain patients. The avoidance cycle is you have a severe flare or emergency, yet you avoid the ER because you're traumatized. You suffer longer. Your condition gets worse. And when you finally go, you're in even worse shape. ER staff assume you're being dramatic because you waited so long. You're treated poorly, adding to your trauma. So next time you avoid the ER even more. But this cycle is literally killing people, and the medical system created it. Why this happens is because they're not trained for chronic pain. Emergency medicine is designed for acute problems with acute solutions. Broken bone, said it. Heart attack, treated. But chronic pain is complex, long-term, with no quick fix. And ER doctors aren't trained in any of that. Most emergency medicine residencies include less than 4 hours of chronic pain education across 3 to 4 years of training. And some have 0. So instead of admitting limitations and providing comfort care, they just don't help. They're operating from fear. ER doctors are terrified of the DEA, lawsuits, and being accused of contributing to the opioid crisis. And when a chronic pain patient comes in, they see liability, not a patient in need. Their fear overrides their duty to provide care. They're pressured by metrics. ERs are judged on speed, door-to-door time, length of stay, patient throughput. But chronic pain patients mess up these metrics because guess what? We're complex. We require time and careful assessment. So from an administrative perspective, we're problems to be shuffled out as quickly as possible. And the system incentivizes dismissing us, not helping us. So here's what needs to change. There needs to be mandatory education on chronic pain. Every ER provider needs training on pain neurobiology, how to assess flares, trauma-informed care, and distinguishing legitimate need from drug seeking. This should be required for licensure. Standardized protocols, evidence-based protocols for assessing crisis versus baseline, and providing pain relief during evaluation, communicating with regular providers, and appropriate emergency treatment. Your comfort care should be standard. Even if you can't fix a chronic pain flare, provide comfort, IV fluids, anti-nausea medication, a quiet room, appropriate pain medication while evaluating, a compassionate presence. Just because you can't cure someone doesn't mean you can't help them. We've got to take accountability for discriminatory treatment. Because when patients are dismissed without examination, humiliated, or denied appropriate care, there needs to be consequences. Patient complaints should be investigated. Discriminatory providers should face disciplinary action. See, there needs to be better documentation standards. Subjective notes like patient appears drug seeking should not be allowed with objective evidence. Patients should have the right to review notes immediately and add their perspective. You need dedicated chronic pain pathways. Some progressive ERs have created dedicated pathways with trained staff, fast-track protocols, and coordination with regular providers. And this shouldn't be rare. This should be standard. Some ways of protecting yourself. You've got to prepare documentation. Bring a letter from your doctor, complete medication list, recent test results, treatment history, and doctor's contact information. Take an advocate with you. Don't go alone if possible. Someone who can advocate, witness treatment, and push back if you're being dismissed. You've got to use specific language. Say, I'm having an acute exacerbation of my chronic condition. Describe your specific symptoms beyond pain. Explain what's different from baseline. Ask for specific interventions and document everything. Take notes on who you saw, what was said, when. Ask for copies of all records before leaving. Write down provider names. Note if you're denied care or treated poorly. And know your rights. You have the right to be examined. You have pain addressed, to see records, to request a different provider, to file complaints about discriminatory care. At the end of the day, the emergency room should be a place of help and safety. Instead, for chronic pain patients, it's often a place of trauma and abuse. We're accused of drug seeking for having medical conditions, dismissed for reporting pain. We're gaslit about our experiences. You get threatened with security for advocating for yourself and developing medical PTSD that prevents us from seeking help even in true emergencies. Sometimes it causes deadly consequences. If you're an ER provider, I know your job is hard. I know you're under pressure, but your chronic pain patients are suffering, both from their conditions and from how they're treated. So please get educated. Check your biases. And remember that every frequent flyer is a human being in crisis. Your compassion could save someone's life. Your dismissal could end it. And to chronic pain patients, your experiences are valid. You're not making it up. You're not being dramatic. You're not drug seeking for needing help. The system has failed you, and the bias is real. Your trauma is legitimate, and you deserve care. You deserve respect, and you deserve to be believed. Share this episode, tell your stories, demand change, file complaints when mistreated, and support advocacy organizations, because this can't continue. People are suffering, people are dying, and people are being traumatized by the very system designed to help them. Things can change, but only if we speak up, only if we refuse to be silent. Your voice matters. Your experience matters. Your suffering matters. Thank you for tuning in for this episode of Painfully Real. If this episode triggered you, I hope it validated your experiences. You're not alone. Thousands have lived this nightmare. And together we're going to make sure that the next generation doesn't have to. Until next time, take care of yourself. Protect your peace, and remember, you deserve dignity, respect, and appropriate medical care. Your life matters. Don't let trauma from the medical system cost you your life.